Now you're going to hear from an obstetrician gynecologist about all of the hormones that we're required to take. We're going to learn a little bit about osteoporosis. We're going to learn about those female replacement hormones. We're also going to hear from Dr. Tamara Huff, who's an orthopedic surgeon with the Mayo Clinic in, I'm going to say it Waynesboro, I say it wrong. She's from the Mayo Clinic in Jacksonville. She does orthopedic surgery in South Georgia, those areas that we talked about a little bit earlier. I'm extremely proud of Dr. Tamara Huff because I'm going to call her a pipeline baby. She was a graduate of Jack and Jill, and for those of us who are Jack and Jill mothers, she was a president of one of our Georgia chapters. And I'm happy to say that she has recently become a Link. She is a former AeroLink and now a Link. So we're super proud to have Dr. Tamara Huff here from the Mayo Clinic in Jacksonville. We're also happy and proud to have Dr. Taniqua Miller, who's from the Emory Department of Obstetrician and Gynecology. She's a certified menopause specialist. She's a graduate of Harvard Medical School, but she is here with us here at Emory. So at this time, I'd like Dr. Huff and Dr. Miller to come forward to talk to us about bones and hormones.
Good morning. Thank you so much for having me today. My name is Taniqua Miller. This is my first time attending this conference, and it is absolutely outstanding what I've seen so far. Such an amazing resource for our community. So thank you again for the invitation. So we're going to talk a little, I love talking about hormones, okay? I think that there is a misunderstanding, let's just say that, a misunderstanding about the use of hormones in women. I love treating the symptoms of women, especially through the menopausal transition, and hormones do play a role there. Some of my discussion regarding hormone therapy will focus specifically on cognition, as this is what the talk is about. But definitely for questions, I'll be more than happy to discuss the role of hormones in your life. I have no financial disclosures. So I want you to meet a friend of mine, or a patient of mine. Her name is Jan. Jan is really maybe a compilation of several different symptoms and women that I've met over my years at Emory for the last 4 years that I think about and is what gives me such passion about treating women going through the menopausal transition and beyond. She's 52, she's married, she had one child who is now in college, yes, and out of the house. She works as an executive for a large advertising firm, and I've been seeing her over the last couple of years, and she's noticed some changes to her menstrual cycles, not so much in the way of having vasomotor symptoms, but definitely skipping cycles, maybe some irregularity here and there. But this time she comes in and she says, you know, Doc, I have such increasing anxiety lately. I don't know what the issue is. I have this large project at work and, you know, I would knock it out of the park any other day, but I just feel such increasing anxiety and I really don't know what to pin it on. My sleep has been poor. I usually get to bed around 9, but now I'm getting to bed around 9, up at 5, but not really getting to sleep until about midnight. So really only yielding about maybe 5 hours of sleep a night. And just feel overall when I get to work, I'm just having such trouble focusing. I don't know what the issue is. I'm not really sure what's going on. Her mother, who is 82, recently had a hip fracture. She fell and broke her hip. And so the family decided that it was probably a good idea just to have the parents move in just for a short time, and they've been there for the last 2 months. So we know Jan, right? We know someone like Jan. We know Jan, she's a colleague, she's a friend, she's a sister, she's a cousin. We may be Jan. And I think that her story can be very typical of many of us in the room because not only is she facing some of the questions, could this be my hormone, but also other midlife stressors that could come about. And we'll explore some of these in the talk. So today I want us to focus on the impact that the menopausal transition has on perceived memory, this kind of lack of focus, this overall increasing anxiety that some women experience. Explore some of the other social stressors, and again, hitting on some of the things that we've already seen today from the different presenters, some of the other social stressors that can have an impact on our perceived memory impairment. Differentiate between memory impairment and dementia, and we talked about that in the last session. and explore the impact of hormone therapy on memory impairment and Alzheimer's dementia, and kind of get some good answers about what is good, what is not, what can we do. So upwards of 2/3 of women will complain of a memory complaint during the menopausal transition. That's a lot. That's 2/3 of women. And imagine, it's right for many women, they're in the middle of their careers, they're raising teenage children, and all of a sudden they're hit with these changes of menstrual cycles, but then also of just cognition. And this can be incredibly scary. Walking around one day and you're like, wait, what was that thing that I was thinking about? Poor focus, word finding difficulties. Can't really remember. What did I do with my keys? What did I just say that I was going to do like 2 seconds ago on my way to the fridge to get water? I don't really remember. What did I come in this room for? What did you just say? That's a big one. What did you just say? You're looking at the person, you're still saying, what did you just say? And then just the overall feeling of I can't focus. It's completely disarming for many women. They feel that literally a light switch has gone off and all of a sudden they just don't know who this person is anymore. I'm going to do just a little basic science and really see where the research derived from the role of estrogen. So when we look at memory and function, we look at the hippocampus and we look at the prefrontal cortex, really the responsible parts of our brain for long-term memory, working memory, memory retrieval. And when we look there, estrogen receptors are in abundance there. And we think that estrogen really potentiates some of the work of the neurotransmitters that are released there, really potentiating the work, promoting neuronal growth, memory connections. So you can also assume that during this menopausal transition where you're getting some fluctuations in estrogen in particular, that fluidity is lost, that you don't necessarily feel those connections are really taking hold like they used to. So there have been many studies that have looked at this to see whether or not that estrogen, is it really like the menopausal transition that's doing this? Is it really just a function of stress, or is it a function of just age? And this one particular cohort longitudinal study that also looked at different aspects of women's health, specifically looked to answer this question and saw that women going through this menopausal transition did have memory issues, that it was something about this time in life, not just based on age, not just based on stress, that really, it was a real effect. But fortunately, this effect seems to rebound in the postmenopausal period. When things kind of settle out, women start to feel a little bit more clarity. And when you look at the other stressors that you face during this time of life, like depression, like depression and anxiety and sleep, as well as some vasomotor symptoms, you can take all of that out, and there's still something about this period of time that has an impact on the perceived memory complaints. So many of my patients then say, well, is this really all in my head? Is this a permanent thing? Is this something that I'm really going through in isolation by myself? And there's always this question, is this a really true effect? Like if I objectively tested you, is there really something about this transition that is real? If I say that I have focus issues, when I test you for focus, do I actually perform worse? And there was a study that actually looked at that. And fortunately, it showed, like, if I gave you a list of things to remember, the women were actually okay with recall, they were okay with verbal memory. But what was really disturbing to me was that they had any tasks that required like multi-steps, that required complex thinking, that required increased detail and attention, that those women performed poorly during this time. They also then looked at women to see, well, what other factors could they identify to potentially have issue, like depression, which is we talked a lot about, like sleep disturbances, which can come about for a host of different things. Some of the complaints that come along with hot flushes and night sweats, poor sleep as a result. And then some things that many women don't like to talk about, but just feelings of well-being, feelings of attractiveness, feelings of sexual satisfaction. In fact, many of my patients, one of the biggest complaints that they come and they say, I'm getting a lot of fat in here. How do I deal with this? This is really bothering me. I don't want to go to the beach anymore. I don't want to be hugged on anymore because I'm very self-conscious about how my body's changing during this time. Those women that identified with any of these, they performed worse. So there was a baseline deficit, but then if you had these other issues, you performed worse. And so it becomes, well, what is the real issue? Is it a midlife stressor that's really compacting this? I think it's both. it's something about the hormones, but then also, it also coincides with a time in life that is incredibly stressful. Caring for teenage children. I had one patient that just sobbed in the office because of just difficulty navigating school and raising a teenager. Very, very challenging now. Caring for aging parents. I think we learned a little bit about that, the care, that's like the equalizer, that all women will become carers. But caring for aging parents tends to be incredibly stressful. The role is reversed. And while you're still dealing with your mid-career life and if you have children, dealing with your children, now to deal with the aging parent can be incredibly stressful. The vasomotor symptoms that go along, causing poor sleep. I think anyone who is sleep deprived, you're not your best. You're not thinking well. The general sense of stress, just feeling stressed. You ever ask somebody, how you feeling? I'm feeling stressed. You know, that just general feeling of being overwhelmed. Work demands, so if you're mid-career and you're going up in your company or you're going up in your work, just the increasing demands of work. Marital discord, big one, especially when you consider that during this menopausal transition, many women have different feelings about intimacy. Health problems, emergence of health problems that may be related to age or not, as well as financial challenges, especially as you start looking, okay, retirement is near. How am I really going to prepare for this? Or putting a teenager through college, how are we really going to make this work? It becomes incredibly challenging and stressful. I also wanted to take an opportunity to talk about alcohol and substance use. You'd be surprised that if you start asking patients, well, tell me, how much do you drink? Patients drink a lot, especially when they do. It's true. I say, well, tell me. Oh, my best question, especially when we start talking about nutrition and exercise, and I'll say, tell me what you had for dinner last night. You say, you really want to know? I said, I really want to know. So they'll start off, oh, I had some salmon, some vegetables, bottle of wine.
Bottle, yes, keyword being bottle.
So the bottle of wine, I mean, we could talk about the calories in that, but then also talk about how patients are medicating. They're kind of blocking it out. The stress and all of the other things get to them, and that's a way to cope. That's a way to treat. And some women do, in fact, require treatment for anxiety, for sleep, for depression, and these medications in and of themselves can have an impact on your perceived cognition. So then this is the age-old question. Please, hormones. Please help me, hormones, okay? And the next couple of slides that talk about hormones in particular focus specifically on the impact of hormones for cognition. The impact of hormones for vasomotor symptoms and hot flushes, I'll be happy to answer as part of the question and answer session, but this specifically focuses on cognition. So physicians, when we look at that slide, when we look at the hippocampus and the prefrontal cortex, and we know that estrogen potentiates these connections and really strengthens memory and provides that fluidity, women and their physicians have been looking to hormone therapy for a while now, correct? Well, and I anecdotally have patients that say, yeah, you put me on this medication for my hot flushes and I can think straight. And some of the initial observation studies showed that women who were on hormone therapy, there was a cognitive benefit. But then when you actually started systematically dividing women, okay, you go on this medication and you go on nothing, those effects really didn't pan out. And part of it is maybe those women in those initial observational studies were just at baseline healthier. That's why they were selected to be on hormone therapy to begin with. We really don't know, but that's one of the thoughts behind it, that there was a bias in those observational studies. As I know all of you have heard about the Women's Health Initiative. We saw it on one of the slides, and it was really groundbreaking in terms of how we treated hormone therapy. But a separate portion of it specifically focused on memory. And what they found in the women that were on the hormone therapy in that study is that actually the cases of dementia were twofold higher than in the placebo group, which is kind of scary.
Can you say that again?
They were twofold higher in than the placebo group. But the limitation of the study was that those participants who were receiving the hormone therapy, they were older generally, and clinically we don't typically start patients on hormone therapy in their 60s. We typically start right around the time of the menopausal transition or immediately post-menopause. So the question becomes, well, if you have a younger cohort of patients on hormone therapy, could they benefit from it? And so the study then looked at the younger cohort of women and saw that from the age of 50 to 55, that sure, maybe, I think they were slightly better, but they really weren't very significant. Now, this data does not take into account women who had early menopause. If we consider the average age of menopause 52, women who were going through menopause beforehand, or women who had surgical menopause, who had hysterectomies and removal of their ovaries, it didn't take into account those women separately. So there's some limited data, but maybe there is a benefit for hormone therapy in that population. So this doesn't mean that you shouldn't go on hormone therapy. If you're having other symptoms that, like hot flushes is completely disruptive, night sweats, or anything like that, there's still a role for hormone therapy in your life. But to specifically use it for cognitive benefit, the data is just not really there. And part of it is like, well, why the difference in age? And I think we talked a little bit about that, but it has to do with as you age, your risk for cerebrovascular disease increases, and maybe the risk of estrogen compounds on top of this the risk of stroke as well as the risk of blood clot, and can worsen brain health. So the overall recommendation is that hormone therapy is not indicated for the prevention of dementia. Again, may be indicated in other circumstances for vasomotor symptom control as well as some genitourinary symptom control, but not necessarily just to specifically treat cognitive decline. And that some women who are initiated on hormone therapy may actually have a worsening of symptoms after initiation of hormone therapy. So this is my favorite part to talk about patients. Well, what do you do, right? I just told you that estrogen is not the magic bullet. Well, a normal part of aging is that we, just with age, may not be as sharp, right? So to-do lists, huge. Create a to-do list. One of the best things that I tell my patients about is journaling. This is something that I feel like we do as we're teenagers. We journal because that's our secret space, and then it goes by the wayside because we're too busy with life. One of the things that I recommend is having a journal at your bed table. So a lot of my patients say, I just have so much, my mind is always racing, it can never settle down. Well, it's because you're trying to remember too much stuff. And so have a journal, have your to-do list. Journal out what you're thinking. I read this article and it talked about the greatest speakers, the greatest leaders, that they have like a whole squadron of assistants and analysts and things like that that keep them on schedule to the minute. So every time that they're at a presentation, they are completely focused. They know that this time to this time is taken care of, and then they move on to their next activity. They were specifically speaking about the president, that he's always on, he's always focused, he's always engaged, and then on to the next thing. And it talks about this rehearsal loop, that your brain is constantly trying to remember. So you say, okay, I have to go to the grocery store, wash the car, pick up this and that. Well, your brain is constantly trying to remember that. There's no way that you can remember all of that. And so writing it down, you cancel out that rehearsal loop, and it keeps you engaged. So when you go back to your list, you say, okay, I'm going to do this now. Kind of what we heard about earlier. No multitasking. Focus on one thing. The other thing that I find is very useful is talking to other women. The topic of menopausal transition tends to be so taboo. Nobody really wants to talk about it. Or you see the lady in the corner with her fan at work, and everybody's like, I know what she's going through. But nobody talks about it. Or you're sitting there and you're like, where are my keys? And no one talks about it. No one talks about it. And so what I encourage my patients to do is talk about it with your family. And then all of a sudden, at Thanksgiving table, you're like, yeah, this happened to me. Auntie Pearl says, oh, you know, that happened to me too. Or mom says, that happened to me too. And then all of a sudden you have validation. Somebody has substantiated what you're feeling, what you're going through. And something in and of itself, just that recognition that what you're going through is a real reality is actually a great thing for many of my patients. We talked a little bit about sleep, and we'll get to that. But yeah, get sleep. The big thing are the tablets, the phones. A new thing that we start in my household, it doesn't always work with my husband. Put your tablet, your phone in the kitchen and get an alarm clock, right? It's like, oh yeah, because what happens is now you're up. We know that bright screen has an impact on our sleep, our ability to fall asleep. And now, I locked myself in the bathroom and I was on Facebook for like 30 minutes. And 30 minutes disappeared. And I'm like, wait a minute, what did I just do for the last 30 minutes? And my kids are knocking on the door, Mommy! And I'm like, oh. So much time can get lost in some of the distractions that we have. And so really valuing your sleep, improving your sleep, creating a little bit of a regimen, you know, nice shower, close the curtains, make it a ritual and get your sleep, improve your sleep, value it. as well as exercise. And we're going to talk a little bit more about exercise and its impact that it also has. So just to switch gears a little bit, not to just kind of cognition issues and memory issues, I like that, no problems, issues, but to talk a little about Alzheimer's disease. So we hear the most about it because it's the most common cause of dementia, accounting for about 50%. And it's a loss of memory, but not just loss of memory, but really your intellectual capabilities, your ability to function independently. And early symptoms are this deficit in episodic memory. Symptom progression happens over time, and the good news is that it clinically is not very apparent before the age of 60. In fact, 96% of the cases are made, of the diagnoses are made after the age of 65. So we talked a little bit about this earlier, the tangles in the plaques. You Google Alzheimer's, tangles in the plaques. What does that mean? It means of what, if we looked at the brain under the microscope, you see these phosphorylated tau proteins and these plaques with amyloid beta. But for me as the gynecologist, I'm an estrogen person, so what does that have to do with anything? Well, estrogen has actually been shown to reduce the phosphorylation of tau protein in the lab, as well as the formation of amyloid beta, so it makes sense. Aha, estrogen is the answer. But like I alluded to earlier, for older women who have dementia, if you diagnose dementia, there's no cognitive benefit of putting on estrogen therapy. And all of the medications that you saw earlier are still at the forefront of how we treat Alzheimer's patients. And estrogen progesterone therapy, when initiated remote from menopause, and we're not talking about that menopausal transition stage, but remote from menopause, they may actually increase your cognitive risk. Again, data are limited, but there's some studies coming down the pipeline to see if there's a way. So my patients then say, okay, I have these memory issues, I'm 52, is this gonna last forever? Well, the good news is that it tends to rebound after menopause. But when should you worry? If you have to ask yourself, and that graph was fantastic, that Alzheimer's graph, when you say, I forget things from time to time, or I'm like completely not managing my budget. Those are the things that you have to really worry about. Is there a functional impairment? Are your family members worried about you? Is there a family history of dementia? And did it occur before age 60? And again, about a 10% relationship there. So memory loss is really the hallmark. And I, as an obstetrician gynecologist, if I have a patient that I'm really, really worried about, I immediately send them to my neurology colleagues. You may also be able to be sent to your neuropsychologist, but then also just general well health, having screenings for thyroid disease, having screening for vitamin B12 levels, making sure that there's no other medical condition that accounts for some of the symptoms is incredibly important. And sometimes there's a role for brain imaging, not always, but it can show maybe the presence of previous strokes that could also have an impact on some of these memory areas. So in preparing for this talk, I found this fabulous paper that talked about 3 midlife strategies to prevent cognitive impairment due to Alzheimer's. And I thought it was very doable, it was very attainable, and just very smart, and echoes some of what I've heard. So I felt, when I saw the presentations earlier, I felt very good that this was in this talk. It was overall improving brain health, okay, enhancing your cognitive reserve, and we're going to talk individually about all of these, and then reducing the burden of Alzheimer's pathology, specifically with exercise, because that's been the most studied. So improving your brain health, getting your vascular system in order. If you have high blood pressure, if you have diabetes, elevated cholesterol, if you're obese, do something about it. Work with your physicians to get it under control. We know that there are some familiar relationships with some of these, and some people, again, like Dr. Agarwal said, they put their hands up, I can't do that. Well, no, let's see what we can do to actually get it in control. It's really hard to take the first step, but it takes 6 weeks to make a habit. So I always say, if you can do it for 6 weeks, take your blood pressure on time, walk, really just make small changes to your diet, get the cholesterol in order. It can really, really help. I read this very startling statistic that an extra 10 calories a day, 10 calories is a sneeze, right? 10 calories a day for a year yields an extra 2 pounds, which means that over 10 years, with a little extra of this, and a little extra of that, you've gained 20 pounds. And just having that in my mind, I don't go back for that second Hershey's Kiss. Well, sometimes I do. But it's just kind of that thought that really the small steps that you take can have a huge impact on your life. Cigarette smoking, quit. I think it's been linked to heart disease, cerebral vascular disease, stroke risk, I mean, everything. Cigarette smoking is a big one. And we touched on metabolic syndrome in our last talk. The other thing that happens during menopause is that you get the distribution of fat into the abdomen, and you actually lose muscle mass. So at baseline rest, muscle burns more calories. Well, then you actually start to get that replaced with fat, and some of that fat will then go into the abdomen. So it's two strikes against us, right? But the big thing is, do some strength training. Try to build up your muscle. Try to be mindful of the things that can contribute to some of that obesity. And really, it's not to say, okay, well, look at this graph and this is metabolic syndrome. But really, if you see yourself in some of these parameters, the blood pressure, your glucose, if you've ever been told, oh yeah, your good cholesterol is on the low side, talk with your physician to see how can we get these numbers looking better. The second thing is enhancing brain reserve, and this was also discussed. Do something. I have patients that come in, they're like, I'm retiring next month. And my next question is, what are you gonna do? They're like, what do you mean, what am I gonna do? I'm like, okay, you're retiring. You have to retire to do something, right? You have to stay active. And so engage in mentally stimulating activities as well as social engagement. And some of this research came from the observation that people who had mentally stimulating jobs, had higher educational attainment, they were at lower risk for Alzheimer's disease and dementia. And so there's something there. Get out, do something. I have some other patients that are like, I'm retired and I'm busier now than I've ever been, because they have the time now to do the things that they really enjoy, whether it's in their church organizations, their sorority organizations, or any other civic groups. They're active, and it feels good doing the things that they like to do. So this question always come up, well, should I buy Lumosity? Actually, I've been to the Lumosity website. It's pretty cool. Some of the activities are incredibly hard, but it's pretty cool. But there's actually no evidence that it necessarily enhances cognition to combat dementia. And in fact, it's just a little hyperlink. In fact, Lumosity, one of the pioneers of this, they actually were fined by the Federal Trade Commission for false advertising. So the initial marketing campaign for it said, yeah, you could stave off dementia and Alzheimer's, and that's really just not true. Is it fun? Will it help kind of keep those connections sharp? Sure, but is it going to stop it? Probably not. And then aerobic exercise. So clearly has been linked to cognitive performance and a reduction in Alzheimer's. And there was actually just an article in the New York Times that talked about that even just a short break from the physical activity can have an impact on how you have oxygenation in the brain. And when we talk about those images that show different parts of the brain lighting up and showing that good blood flow, you actually can get impairment for just a short break. So it's something that has to become part of the lifestyle. When we look at mice in a laboratory and they're on their little scooters or their little hamster wheels, they actually showed that they had a reduction in the amount of tau protein, phosphorylated tau protein. So there is something there at a physiologic level as well. So it's not just saying, okay, your brain is healthier, you're getting blood flow, but at the cellular level, it really, really makes a difference. It really, really makes a difference. And in fact, patients who had more physical activity had over a 28% reduction in their risk for Alzheimer's disease. So there's good data there. So these are things that you can do that are very attainable in a chair or on the stair. I feel like Dr. Seuss now, but are very attainable that you can do on a daily basis and make it fun. For many people, this is a complete lifestyle change. You didn't grow up, I had friends that they grew up running 5 miles a day with their dad. And I said, I lived in New York City, I didn't run 5 miles. But it's fun to kind of incorporate new things into your life, try new things into your diet, and make it really fun for yourself. So some key points, just to kind of iterate back on the hormone piece, that hormone therapy, maybe after surgical menopause, early menopause, may lower the risk of dementia in certain groups. The data is a little limited, but there may be a role there. But it's not recommended for primary prevention. And in fact, women who have baseline dementia may be negatively impacted by it, or started later on may be negatively impacted by it. So I just want to say thank you again for having me today, and I'll be more than happy to answer questions during the question and answer session. Thank you.